there's two main types of presentations I see when it comes to limitations at the knee that can result in pain, poor movement, or just poor posture. Now, these aren't always the case. This is just what I most frequently see. So let's break down what I see first and most commonly. This is probably going to be what most people associate knee valgus with, or an inward collapse at the knee. When this happens, you've got, and you guys know where I'm going to start up here, you have a forward pelvic orientation right here. One or both sides of the pelvis is in a forward pelvic tilt right here. When that happens, you're going to have that femur right here slide into internal rotation. You can see what happens to the tibia, the lower leg bone down here. When this comes forward, this goes inward. That's probably going to follow it. Now, for whatever reason, maybe this individual is an athlete, maybe this individual is just lacking external rotation, so they're going to try to find it one joint lower, which would be at the tibia or at the foot itself. Now, when this happens, and this is inwards, you're going to see this tibia turn relatively outwards against this femur that is internally rotated. So because we started in an orientation where this knee was inwards into internal rotation, everything is still probably a little bit internally rotated, but now we have a relative external rotation of that tibia. And then you can see what happens here is you have a torque at the knee, and the medial knee is going to be subject to potentially more stress and pain than the lateral knee in this context. The other most common thing I see is a posterior orientation of the ilium or pelvis on one or both sides. When that happens, the femur slides out into external rotation to follow the pelvis. And if you paid very close attention, what you can see is that that actually increases the angle from the top of the femur all the way down. You can see how this creates more of a Q angle. Now, the Q angle doesn't actually have a lot of validity as it relates to predicting knee injuries or pain, but we can use this as a concept to understand what's going on here. So I will just reference this as a Q angle. Now, when you have this externally rotated femur, under normal conditions, you should see this tibia turn outwards into external rotation with it. So you could have a situation where this femur is in ER, but then this tibia turns into IR. Or if there's a lot of external rotation present, you can see everything translate and migrate outwards into more external rotation. Now, this creates a bowstringing effect of the patella, where this is translated and pulled outwards. And when that happens, you have a lot of torque and pressure of the patella actually moving on the femur and also the tibia. So that creates more of this lateral knee pain and lateral issues of the knee. And that's what you're often, but not always, going to see associated with lateral knee pain. I think it's also important to appreciate that just looking at the skeleton model, totally hands off here, the human body has a natural degree of knee valgus. I think this is a little exaggerated because this guy's not actually touching the floor right now because he's suspended, but every human has a slight degree of knees that travel inward. That's just a normal Q angle, so to speak. But depending on your genetics and how much variability your joints have and your overall posture and lifestyle demands, you can have more or less of this knee valgus, but that doesn't mean it's an issue. I'm sure you're going to be shocked to know that I'm going to start at the pelvis and work my way down from there. So if I had a femur that was in external rotation due to the posterior orientation of the pelvis, then we need to probably address that first and allow the pelvis to have variability to move into internal, external rotation as necessary. And then we can start to go down the chain a little bit more. But if we had a pelvis that was in internal rotation, femur in internal rotation, then we probably need to facilitate a little bit more of the variability that allows us to access that external rotation of the hips. If the goal is to improve internal rotation mechanics of the pelvis and or the femur, then I'm probably going to start with something a little bit more ground-based, like a 90-90 hip lift with a ball hold. After that, I'm probably going to do something a little bit more dynamic to cinch up that movement and make sure that they can hold it through a varying degree of range of motion, like a staggered stance deadlift. I'm partial to these staggered stance deadlifts because I think that they're really beneficial for getting this one side of the pelvis, or you can do it on both sides, to go into a lot of internal rotation, because as you get to about 90 degrees of hip flexion, you can see how that femur is going to be pushed back into the hip socket here, and you're going to see the sacrum turn to one side for a lot of internal rotation. And if you have the issue on both sides, then just do it on both sides. If the goal is to restore external rotation of the pelvis, then I'm probably going to choose something in low levels of hip flexion first, because that's probably where most people are starting. Most people don't have the hip flexion to go very deep into it at first without compensation. So I will probably choose something like a hook line bridge to allow them to get into less hip flexion if they don't have it at first, which will help them bring the sacrum back and also get a little bit more external rotation. After that, I might choose something like a supine alternating cross connect to allow me to get a little bit more hip flexion, which is biased with external rotation. If you bring this hip back quite a bit past that 90 degrees of hip flexion, that's going to cause the femur to go into more external rotation. And then we can do it on both sides to help facilitate a little bit more. In my experience, in most cases, addressing this usually clears up a lot of the issues. And then the rest of the chain follows as the body adapts to the new gained variability within the pelvis. But if that's not the case, then I'm going to create another video going down even deeper into the foot and how that can be affected by these presentations that we see today, and what we can do to get a little bit more specific with the work of the tibia and also the foot.